Thank you very much, Kenneth, for your kind introduction. Hello, good evening, everyone. I do apologize if I will be unable to sustain your engagement as saw in the previous panel. I see most of you are still young people, and I'm an old man. I may not be able to sustain that motivation I've seen. However, I'll try my best. When I was invited to talk at this symposium, I was given some questions, and I asked myself, will I be able to answer those questions? First of all, I didn't know that our program was a success story. But what I would like to say right now, I think I don't want to take credit for what I haven't been able to accomplish myself. This program, we've been implementing it in very close collaboration with another organization called Human Development Initiative, chaired by Dr. Kagaba, who is sitting on this panel. And actually, when we both started the discussion to apply for funding to this program, I was initially skeptical myself, because the target group was female sex workers and men who have sex with men. I discussed with Kagaba, and I did ask, do we really have MSM in our country? Will we have enough data to support our application? Kagaba told me, yes, we have, but I didn't trust him. And then I asked him, if at all possible, before we even start writing this application, can you introduce me to at least 10 MSM? He said yes. The next day, he brought to me 30 young men who said we are MSM. We started discussing with those young men. They said, which kind of services are you receiving, and many things around. And then I was convinced. Dr. Kagaba, he had been doing advocacy for these young people to be recognized as one of the key populations for HIV/AIDS transmission and acquisition in Rwanda. And finally, our national strategic plan was able to include key populations as one of the key target populations in our fight against the HIV epidemic. So what we've been doing for the last 4 years, together with HDI, we first started with these associations of young MSM. They had already created their own associations just to make sure they are able to fight against the stigma they are facing within the Rwandan community. So we met with their leaders, we discussed with them which kind of services do you need for HIV prevention. And together we're able to describe what were the critical needs. We did find, for instance, that when they go to the healthcare facilities, let's say if someone is suffering from rectal gonorrhea, they fear to openly discuss this with the healthcare provider. Or even if they do report to the healthcare provider that they're experiencing something in the rectum, the first answer from the healthcare provider is, how did you get that infection in the rectum? Instead of listening to the gentleman, the healthcare provider would first ask, how did you get that? So we really saw that really stigma was a very big issue for these young men, and we tried our best. How can we make friendly environment to them so that they can easily come to our services and request services that they would most need? In my organization, it was first very difficult for us to tell my colleagues that we are going to do the work for HIV prevention among MSM. When I first discussed with the nurses who were very experienced in providing HIV counseling and testing services, they first told me, oh, maybe the first thing to do is, can we pray for them so that they abandon this bad, so sorry to say that, they say no. A friend of mine who is working with MSM in Kenya, showed me a link that is providing an online training about HIV prevention among MSM. As Kenneth introduced me, I've been in the field of HIV/AIDS prevention for the last 30 years. But by going through this online training tool, I was enlightened. First, when I saw, the first time I said, water-based lubricants. I say, how come? Water-based lubricants, do these really exist? And I'm someone who, in the past, had been the director of the National AIDS Control Program, and yet I didn't know anything about those water-based lubricants. You can imagine other healthcare providers, they don't know anything. So I do think really, for this program to be successful, we must also train our healthcare providers because they are completely ignorant. This is one thing. Second, we have to make sure that we have a friendly environment for those people. When I discussed with my colleagues at work, when we were just about to start this program, sometimes people would say, no, creating a positive environment is something that will take too long time. I say, no. I say, this is very critical, and now realize that there is an issue. And then I called an all-staff meeting to tell them very soon we initiate a new program targeting MSM. This MSM, they may be your brothers, they may be your cousins, they may be your nephews. But please, here in our healthcare facility, we must make sure that they are receiving the right care as any other person. And I did tell them, this is not an advice I'm requesting from you, this is an instruction coming from the boss. Then they had to cope with this new environment. And actually, when we started receiving young MSM, they were quite happy with the kind of services they are receiving, the way they are being received, and together we continue to implement our program. However, although you are saying that it's a success story, in the last 4 years, we have reached only about 2,500 young men. And yet, in a recent survey we've conducted to estimate the number of MSM in Kigali, it is estimated around 6,000 people, which means we haven't yet accomplished a lot. We still have to find where those others are. There's still an issue with stigma. Though the men we are receiving in our services, both at Projet San Francisco and HDR, we have relatively very young men. But when we are doing this survey, we realize there is another hidden population, mostly old men who do not want to be visible. How can we reach these others? It's still a challenge. You've said our program is a success story, but we have only been able to provide services only here in Kigali. And yet, we know that in other provinces we have this population as well, meaning they do not have access to the care that they would need. What else we have learned from this program and why MSM that we receive in our program do like really our program. In the survey we conducted last year, about 63% of MSM that we interviewed said they didn't know where to get access to, they could purchase lubricants. Second, the lubricants are very, very expensive. So the group we've been able to reach, they like our program because they can get access to lubricants for free. This is an incentive for them to continue coming to our programs. Another challenge, when I compare the MSM we receive in our services to the estimated, the other group we received during the research program, the prevalence of HIV in our target population, those coming for services, is only about 6%. When we did conduct this survey, the prevalence was 10%, meaning probably we are not, there is another higher risk group, a subset of a higher risk group in this MSM that we are not able to reach. How are we going to reach them? This is a question that probably I would like also your feedback. How can we reach those other people who have a much higher risk and yet don't want to come for services? And how can we provide them with services? How can we make them comfortable and allow them to come to get access to the services they do need? I think I have more questions than answers. I hope that I'm not disappointing you, but I want just the session to be, the discussion to be live and really targeting the right questions. Thank you very much.